Hi, my name is Dave Spoolma, and I'm a student at the Mid-America Christian University, and I'm doing a case study on R.C. She's a 35-year-old white Caucasian female. Her presenting problems is that she pretty much is down all the time. She feels badly about life. She's already on medications for depression, anxiety, and vertigo, and she was born with a bad hip, which has turned into arthritis. She has really big up and down points in her life at random times. And then in addition to that, she married a husband who constantly puts her down and piles on her self-image in a negative way. They have financial problems that are stressing the marriage, and with her two sons, her younger one has autism, and he is awful hard to deal with for that marriage. She doesn't sleep well. She's reported that she has eating problems where she splurges and purges, and then she doesn't have much of a support system either, in that she's distant and angry with her family of origin. She's turning distant and angry with her husband. She is isolating herself more and more from her support network of her friends and her church. She has reported that many times over her life she's had suicide ideation. She's even made plans. She has not attempted, but she has been really tempted to do so. Her body and her mind always feels weak and powerless. She has quite a few panic attacks, and then she walks in guilt and shame over her past abuses, which we'll get into in a little bit. She has a lack of concentration and focus. She has a hard time making decisions, and it doesn't seem like she can find anything where she could have pleasure in anymore, even things that she used to have pleasure with in the past. With her family and client history, she was physically abused a year into the relationship by her boyfriend, who is now her husband. There is no current physical abuse, but there is a lot of mental abuse. He puts her down constantly, and that just fans into flame all the mental abuse that she's had by her family of origin. And she was hoping to marry to be able to get out of that, and it just seems to perpetuate. She has undergone beating and burning and hitting by her family of origin. There's been severe neglect from mother and father growing up, in that we'll get into it a little bit, but mom had some mental issues and father was an alcoholic, and so R.C. did a lot of raising of herself and was left alone many times doing so. There was severe neglect and sexual abuse by family members at age 8 as well as at age 10. And then as she thinks about getting out of financial trouble and maybe securing a different job, there's not a lot of opportunity for her because she only has a high school education. Like I mentioned, R.C.'s father is an alcoholic, and R.C. has witnessed her mother being physically and mentally and sexually abused by her father pretty much her whole life. And her mother has been diagnosed as bipolar. Let me put some positives in as well. She's no longer living in denial, and the tests that we're taking, the MMPI and the MCMI, do confirm that she's pretty much telling the truth. She might embellish a little bit, make her somatic complaints a little higher than what they are, but she's not living in denial. And R.C. does have a support network with her pastor and her church friends if she chooses to not withdraw from them. She has a deep faith as a Christian, and she wants to get better. She's willing to do anything and take all the counseling necessary to do so. The test that were administered was the Adult Assessment Identifying Information and the Folstein MMSE, the MMPI-2, and the MCMI-4. Other instruments I used for diagnosis was the DSM-5 and the criteria, as well as the decision tree for depression. The results of the Folstein mental status examination showed her scoring 29 out of 30, which she really flew right through that. She didn't have to think very much. She had pretty much a clear focus when she was in my office, and she's mentally normal by way of the status examination. She was right there with me and focused. She was quick to answer the questions, and she did it accurately. The results of the MMPI-2 shows a high T-score in most every area, drawing a lot of concerns, but she's answering with validity and not just answering true all the time indiscriminately. She's frank and she's open. She's not in denial. Like I said, she may exaggerate her somatic complaints and even her pathology, but she should be interpreted, and she shows to be telling the truth the majority of the time. The results of the decision tree shows that she has a depressed mood, not meeting criteria for many of the mood disorders on the decision tree that develops in response to a stressor. The decision tree leads me to the diagnosis of an adjustment disorder with depressed mood. The results of the MCMI-4, there was an elevation of major depression, indication of borderline, generalized anxiety, schizotypal, and avoidant tendencies. And the results of the DSM-5 was that after running down through all the criteria and ruling out medical problems or substance abuse issues, ruling out other disorders, I came up with adjustment disorder with depressed mood and qualifying with mixed anxiety and depressed mood. And there's the numbers, 309, 28, F43, 23. The summary of RC: she has multiple stressors in her life. These stressors are triggered by her parents yet, her husband, her own psychosis, and disorders. Her intensity and quality and persistence of depression exceeds what might normally be expected by the general population, and depressed and irritable mood. She has a high risk of suicide attempt and follow-through, in my opinion. She has a multiplicity of things going against her. She has a history of abuse, which could border on some PTSD. We'll have to look into that. She's present with self-image attacks all the time yet. Financial concerns. She has lots of negative self-talk and schemas going on in her mind. And she feels hopeless, she feels worthless, and has inappropriate guilt. She's withdrawing from her support network, and this will continue to cause relapses and continued maladaptiveness towards healing in her future. And her sleep has to be improved, or else her focus and clarity of thinking will not improve until she's getting better sleep. This is my proposed treatment plan. The assignment asks for 3. Because of the multiplicity of things that's going on with RC, I put 6. Her overriding problem is depression. And long-term goals are to alleviate depressive symptoms and to help her recognize, accept, and cope with feelings of depression so that she can return to a good level of functioning. To develop a healthy thinking pattern and belief about herself, others, and the world so she doesn't relapse into depression. and to develop healthy interpersonal relationships so she doesn't relapse into depression. Objective number 1 is to verbalize any history of past and present suicidal thoughts and actions. Thought we better do that first because it's very serious for her. And interventions for object number 1. First intervention would be to assess her history of suicidal thinking and actions to gather information on her current state of suicide risk. And throughout counseling, continuously monitor and assess her suicide risk. And if I assess she's a danger to herself, to arrange for hospitalization. Objective or treatment number 2 for objective number 1. Refer her to a physician for a medical evaluation to rule out general medical or substance-related causes of her depression. Note the test came back with the insight that she may be embellishing her somatic symptoms, and a good medical examination will help to determine the level of embellishment. Intervention 3. Because RC is already taking some medication, I need to cooperate with the physician's medical evaluation to see if what she's taking is what she needs, and then it will tell her compliance, effectiveness, and possible side effects. Objective number 2. Help RC verbalize a good understanding of depression as well as an understanding of the rationale for her treatment. And to do that, the first intervention will be to discuss through some CBT therapy how cognitive, behavioral, interpersonal, and other factors such as her family history and abuse can contribute to her depression and help her alleviate depression and get to a better level of functioning. Intervention number 2. Assign her to read resources that teach psychoeducational principles regarding depression. Objective 3. Help RC identify and process this by helping her to replace her thoughts and beliefs that support depression. Intervention 1. Help RC learn the connection among cognition and depressive feelings and actions, and assign her to self-monitor thoughts, feelings, and actions in a daily journal. Process that journal entry with her to challenge her depressive thinking, schemas, and patterns, and replace them with reality-based thoughts that are more positive. Intervention 2. Positively reinforce RC's shift from biased depressive self-talk and beliefs to reality-based thoughts and messages that give her self-confidence and increase her adaptive actions positively. Objective number 4 is to help RC learn to start behavioral strategies that overcome depression. And to do that, the first technique or intervention will be to increase her activity with rewards and identify these thoughts and patterns that stop her from acting and thinking positively. Use instruction and rehearsal techniques and role playing and role reversal to get her acting and thinking positively. Then reinforce her success. Intervention 2. Help RC develop skills that increase her likelihood to get pleasure out of her activities. Help her develop assertiveness skills. Get her to exercise. Help her to gather a more outward and external focus instead of internal inward focus. And reinforce her success. Objective number 5. Identify some important people in her life, in the past and in the present, and describe the good and poor of those relationships and help her to verbalize an understanding of current interpersonal problems. Intervention 1. Help her to grieve the death of her grandmother, who is basically a surrogate mother to her. Facilitate her mourning and help her discover new activities and relationships to compensate for her loss. Intervention 2. Help RC to develop new interpersonal skills and relationships. And the last objective is to verbalize how past relationships and abuse may be influencing your current experiences with depression. And to do that, help her increase her insight into how her new role, or role now, could be influenced by past relational patterns and making her vulnerable to depression. Identify those conflicting themes and process them with her to make changes to her current relational patterns, and explore her experiences with caution from her childhood that contribute to her current dysfunction. And I want to add to that, look into what PTSD may play in her life over her past abuses. Third intervention, encourage RC to tell her feelings of anger to me regarding the pain she has experienced in childhood that contributes to her current depression. 4. Make sure to explain to RC how the connection between unexpressed and repressed feelings of anger she has and helplessness and her current depression. And this concludes the project by student David Spoolma.